Good evening, everyone, and welcome to another session of Intellectus Campus. I apologize, we've been having a few technical difficulties tonight. So we have pre-recorded this session. Our host tonight is Dr. Nasir Syed, who is very experienced in sexually transmitted diseases and works in Harare. I've done an introduction to him in the pre-recording. And with that, Pride, can we start the recording that we did earlier? Good evening, everyone, and welcome to another session of Intellectus Campus. Tonight, we're going to be dealing with a very important topic, sexually transmitted diseases. Dr. Nasir Syed is a primary care physician, and he has been part of the TB research trials across Zimbabwe, across Botswana, and in South Africa. And he is a senior partner in a Harare medical practice with extensive experience in medicine, particularly as a superintendent and district medical officer. He holds a Post Grad Diploma in Tuberculosis and Chest Diseases from Karachi University, and he's recognized for his contributions to the Zimbabwe Medical Association. We decided that it was important that we did a refresher on sexually transmitted diseases because they're becoming less and less recognized. So I'm going to hand over to Dr. Syed, and he will show us a presentation. I just need to let the viewers know that there's some fairly graphic slides in this presentation, but I think it's important that we see them. So I'm handing over to you, Dr. Syed.
Thank you, Jackie. Thank you very much. And I'm indebted and very thankful to Intellectus Campus for allowing me to present this very important topic of the era. Definitely, sexually transmitted disease comes on top of the priority of any Ministry of Health issue. So this is primarily directed at my colleagues in primary care practices with very limited resources, and I'm sure they will benefit a lot from this presentation. So it's a refresher. So sexually transmitted infections or transmitted diseases are infections that are primarily spread through sexual contact. They are caused by viruses, parasites, and bacteria, and can affect anyone who is sexually active. Some key facts, they were issued by WHO in May this year, and it shows that 1 million curable STIs are acquired every day globally. In 2020, there were an estimated 374 million new infections. Age group between 15 and 49 is very important. They are usually infected with syphilis. In 2022, they found out. And more than 500 people aged 15 to 49 have a genital infection with herpes and HPV. And with over 311,000 cervical cancer deaths each year, definitely it's a point of concern. And they have a direct impact on sexual and reproductive health. They take the big chunk out of the budget of the Ministry of Health in any country of the world. Another issue is of drug resistance. It's really takes a chunk out of the budget. So we start our presentation with the stars of the show. As we mentioned earlier, these are bacteria, these are viruses, protozoas, and fungus, which cause, and the parasites also, which causes pubic lice, and the scabies, which are also equally important when you consider sexually transmitted disease. In bacteria, prime importance are Neisseria gonorrhea and Chlamydia trachomatis and Trypanosomiasis, which causes syphilis. In viruses, the most important virus, of course, besides the HIV virus, there is the herpes virus, and then hepatitis virus. These are very important, and human papilloma virus also equally important. And the new addition to this group is the Mpox virus. As you are all aware, Mpox spreads through the contact with the secretions, bodily secretions of the Mpox patient. In the protozoa is Trichomonas vaginalis. Fungal infection, as I said earlier, Candida albicans. STIs usually affect these areas because the genitals are more moist and warm, and these environments are ideal for the growth of them. So that's why these areas are most affected by this infection. This is an old slide, a very old slide about 10-15 years ago, and I borrowed it from a friend. It's a very nice slide. It summarizes the main infections, main STIs, which we deal on a daily basis in our practices, maybe private or government, urban or rural, and 15 million Americans are per year infected. This slide also tells you, and it also shows how they are transmitted, which causes it. So when you see a patient with sexual history or sexual complaints, there are two types of patient. One is a symptomatic patient, which is obvious. I mean, it tells you a history of an encounter. But the other very important part is the patient who is asymptomatic. He might have come with another problem and you picked up in the history or examination, or he doesn't have any symptom at all. And he comes with a sexual problem, but you don't find any symptoms or you don't find any signs. These are very, very important patients. They should not be ignored at all. So if a symptomatic patient, you see a male patient will usually have urethral symptoms like frequency, dysuria, and or discharge. Then you might have protective proctitis, anal symptoms. There might be lumps or swellings, and you will see ulcers or sores, and there might be skin rash or itching. Similarly, in a female patient, present with a vaginal discharge, no vulvar symptoms, or vulvar symptoms with discharge, pelvic pain, lumps or swellings like the male, ulcers or sores, skin rash, and itch. These are the primarily most important symptoms you must bear in mind when seeing a patient with sexually transmitted infection or when you're doubting it. So as we proceed with the patient, history is of prime importance. As always, as we are taught in our medical schools, and we have to learn day by day this technique, this is very, very important. So WHO also and the Australian Sexual Transmitted Infection Guidelines and the UK guidelines also emphasize that 5 P's are very important. And these 5 P's are partners, practices, their views on protection from STI, their knowledge or their views, past history of STI, and their intention of getting pregnancy or going for a pregnancy. So partners. The most important question you need to ask is if they have had sex of any kind with another person. If they say no in recent months, and number of partners is very important, very, very important. And in the high income group countries, definitely gender is very important, as well as in the low income group countries. So you have to ask, do you or your partner currently have other sex partners? I'll come back to that because these are very, very important. Sex partner is always of prime importance, seeing a patient. As I said, number and gender are really, really important. And definitely we should never make assumptions about the patient's sexual orientation, gender identity of the patient, or the partners. This is very important. Then the practices, oral, vaginal, anal, and have they had it done with anyone or okay. So definitely protection from STI. We should get the view of the patient, his knowledge also. He might have read somewhere, he might have been told in one of the church meetings, or he might have attended any other seminars in which he had some idea what STIs are. And we should ask about him and his partner that, do they know about STI and what methods do you prefer and how frequently? Because sometimes they not say they're going to use a method, and they might say, very common in our practices, patient says sometimes, in which situation you would have to ask with whom. And then also you have to know about the HPV, hepatitis A or hepatitis B vaccination. And they are aware of the HIV prevention like PrEP or post-exposure. And if they ever have used it or they consider using it, this is a very important thing. Then coming back to the last, have they ever been tested? There should be a past history of STIs and HIV. This is very, very important. I recently saw a patient who came with some complaints, and during the history taking, he mentioned medical history and drug history. He mentioned he was taking some medicines, and on inquiry, he mentioned His partner was sitting next to him, and he mentioned that he was taking HIV medicine, which was like a bombshell to the partner, and he didn't even know. And they have been intimate for the last couple of years. So please, we must ask them if they have been tested for STIs and HIV, or are they currently on any medicine or not. And the last P is the pregnancy intention. If the couple or the person is they're intending to get a pregnancy done, of course, we have to save the baby. If he's been infected with HIV, partner as well, the babies are very important. These are some references for these 5 Ps. If somebody would like to look into the literature, I would be very glad to pass it on. So let's take a pictorial tour, which Jackie mentioned in my intro, and this is a very important. So in examination, you can see one or the two or other. So that's why we treat or we manage these STIs as a syndromes, not individually. So the first pictures, you will see urethral discharges in a male patient, and later on it was confirmed that it was a gonococcal urethritis. You should bear in mind that gonococcal, chlamydia, and in males, especially trichomonas, cause this urethral discharge. So these coexist, especially gonococcal and chlamydia, they occur together. So they have to be treated as syndromic. And now we see a penile gonococcal patient with a superadded infection of a Staph aureus, and you can see some sores developing. If you have taken a smear, it might look like this. Then bacterial vaginosis, there will be a little bit of discharge and the patient's presenting complaints, and the picture would be something like that. I've taken these pictures from STI Atlas. At the end of the slides, I'll give you access or the link to the Atlas. It's a very good Atlas. It tells you about the sites of the infection, symptoms, systems involved, and the bacteria involved. It's a very good Atlas. It has been compiled by the Melbourne Society of Sexually Transmitted Infections, and it's a very good Atlas. I think it's and it's free. You can access it. There is no subscription. You can access it in your surgery anytime. And it's very big aid, especially for us in very limited resource settings. It's a very good Atlas. Then we'll see something about the genital ulcers, a very common presentation. So here the slides mainly concerned with the ulcers which are found in primary syphilis. As we are all aware, syphilis is primary, secondary, and tertiary. So in primary syphilis, you can find these chancres or the ulcers on genitals. So these are a couple of slides. You can see the ulcer. So here you can see a chancroid or an ulcer developing in a secondary syphilis patient on the tongue, and a typical syphilitic rash on the right cheek of this patient. Again, some pictures of genital ulcers with a bubo. So we mentioned in the symptoms, they might present with a lump or a swelling. Here we have compiled a few pictures of secondary syphilis, and you'll appreciate there's one picture, if you look, which shows a very, very characteristic syphilitic rash. You can see the erythema, you can see the spread, you can see the pattern, and also another area of the skin lesion you can see, and then definitely the warts caused by condylomata, as they are called, in the inner areas. And anal warts, very common presentation. We see a lot of them. Similarly, inguinal warts, a collection of warts you can see. And these are, patients do complain, and sometimes they are ignored if you don't examine them in detail. They are in the urethral meatus, you will find these warts, and you can see how clear they are. But sometimes they are there. Patient does mention, but the physicians misses them, and they will examine the outside of the genitalia. But if you look carefully, you can find them. This is the later complications of the STIs when they develop malignancies in these areas. some more genital ulceration. On the extreme, my right, you'll see anal herpes in this patient. And this donor venosus, you can still see how bad the lesions are. And this is the erythema multiformis caused by the herpes simplex virus. The fungal infections, the candidas causing balanitis. And this is a pharyngeal presentation. As you can appreciate, these lesions in the oropharynx, very nicely done. And the candidal balanitis. This is a very common and sometimes dismissed. We keep on thinking about gonorrhea, chlamydia, and syphilis, and the patient is not recovering, and then you realize. And here I will also mention, when you're seeing a patient, please make sure you always do a blood glucose test. This is very important because you can find diabetes concurrent with the STIs, especially these sort of infections. I've seen a lot of patients, and I'm sure Jackie would have seen a lot of patients in which you'll find diabetic patients having these problems. Again, a few more pictures of the candida. Another picture of the candida. So these were the graphics Jackie was mentioning. I'm sure you would have appreciated them. These are very good pictures. So a few words about gonorrhea. And it was not in the literature until 1879. And then Albert Neisseria discovered the organism in the smell of the purulent exudates from the urethra and cervixes of the few patients and few ophthalmia neuratum patients. It colonizes lower urogenital tract, oropharynx, and conjunctiva. So that's why I mentioned earlier, you must ask what kind of whether practices, sexual practices patient has, oral or not. And then it ascends to colonize and infect the normal sterile upper GI tract. It can invade through the blood infection. So if we don't treat gonococcal infection appropriately, it can lead to complications like epididymitis or PID in a woman. And it has been mentioned in the literature that it does facilitate the transmission of HIV. Slide summarizing chlamydial symptoms in a man and a woman. A man will present definitely with a painful ejaculation or a penile discharge, or you can find scrotal swelling. In a woman, we can find her having dyspareunia, some PV discharge, or in between periods bleeding. Few words about syphilis, either acquired or congenital. Acquired is usually via direct sexual contacts. Congenital, the vertical transfer. So primary, secondary, tertiary, latent syphilis. So a few words about the diagnosis of STI. The accurate diagnostic tests for STIs in high-income countries are very expensive tests. They're very specific and especially are very important when they're done on asymptomatic infections. Recently, two papers were done in Harare by a colleague from UK. The area where I practice, a very high density area of Harare, was selected as one of the sites to collect samples. And they were doing a study on asymptomatic patients. The papers are out. I haven't got hold of those two papers. They've been published. As soon as I get them, I will definitely pass on to Jackie, and then Jackie can post on to the forum for our benefit. So at the moment, however, like I mentioned, in our lower and middle income countries, we are not privy to those accurate diagnostic tests, but few inexpensive, rapid point of care tests are now available, especially for gonorrhea, chlamydia, syphilis, hepatitis B, and HIV. And they are really helpful to us. I'm not very sure about the pricing, but I've seen them being used, and few labs are doing it. So now you have done the examination, you have taken the history. Now, how do we investigate? So You will hear a lot about NET now in near future. In most of the STI seminars and lectures, people will mention about NET. So what is NET? NET is nucleic acid amplification test, and you can actually use it in your own surgery. There are different types, different prices, but it will be a very, very convenient test you can use in your own setup, urban, rural, whatever practice you have, and you can have a spot diagnosis of these diseases like we diagnose. I've seen NET being used in serum cholesterol and NET used in blood glucose testing. So these are, as I said, these are very fast and easy options as opposed to the lab tests, which are very, very expensive. And sometimes patients don't go for their test because they can't afford it. So as you proceed with a urethral irritation in a male patient with dysuria or discharge, the first void 15 to 20 mils of urine, and for chlamydia, gonococcal, and Mycoplasma genitalium. So if the lab gives you a result of Mycoplasma urease, you don't have to worry too much. But if it shows Mycoplasma genitalium, you should worry. Then you have to treat them as a syndromic treatment. And the swab of discharge definitely should be taken. It is definitely very important. So if you can get a swab of the discharge, you don't have to do a urethral swab. You can do the swab of the discharge. You must inspect the perianal area and palpate the anal canal, and you must look for the ulcers and fissures, and then you can take a swab for all these STIs mentioned here. So if there is an anogenital ulceration, we must think about syphilis and herpes, chancroid and LGV, and swab should be taken and should be sent in, and especially for herpes simplex and syphilis, definitely should be done. So rashes and itches, they are also the same investigation. You should, if it's generalized rash and itches, first thing you think about syphilis and acute HIV infection. If it's anogenital, you think about genital herpes and HIV infection. They go hand in hand. So if a female patient is in your practice, you are seeing or you're inspecting a patient, here also you have to think about low risk females and a high risk female. So especially female sex workers, high risk patients, the genital examination is mandatory in these people. You must do a thorough genital examination and think about HIV serology, syphilis serology, hepatitis B serology if they are not vaccinated for hepatitis B. And if it's a low-risk female patient, as I said, in the male patient also, you do the same things. You do a NAT test, and genital examination is optional, but I think we should do, especially if it's an asymptomatic patient, it should be done. You cannot avoid a genital examination. So if she has a pelvic pain, then we should think about gonococcal, trichomonas, and Mycoplasma genitalium. NAT testing would be really a gold standard testing, and cervical bacterial swab for microRNA culture. Here I would like to request before I proceed, when you are seeing a patient with STI and you are ordering investigation or you're taking a test, and sometimes you're in a position where you cannot, or the patient cannot afford a test, do not delay treatment. As soon as you have discussed about the investigations, treatment is of prime importance. It will lead to complications. Patients are lost for follow-up, especially in source-limited settings. Please do not delay treatment. Treatment has to be given. This is very, very important, especially in STI. So if you see heterosexual man with injecting is a drug users, then HIV serology, syphilitic serology, hepatitis B, and hepatitis C is very, very important. Sometimes primary care physicians forget, or sometimes they don't think of hepatitis serology. This is a very important because hepatitis C also causes a lot of complications later on. Similarly, it's the same case if you find a female patient who has been using drugs. These battery of tests should be done. So if you see a woman with a vaginal discharge and vulvar symptoms, as we mentioned earlier, more or less same investigations are ordered. And as I said earlier, empirical treatment may be given before the results are back. your clinical suspicions is of prime importance. So sometimes, people ask what swab should they use. So two types of swabs are needed in STI, pharyngeal swabs, anorectal swabs, and the genital swabs. So most of the labs have got these swabs. I'm aware a lot of labs have got these things, so you should demand from them. If you're referring patients to this lab, they should provide you all these swabs. So as we were discussing earlier, there is a greater risk of patients having diseases which can be passed on to others unknowingly, because STIs initially do not cause symptoms. So point is valid. Asymptomatic patient is equally important as a asymptomatic patient. So when an asymptomatic patient comes to you, you should always be suspicious of chlamydia, Hep B, HIV, and syphilis, and gonorrhea, of course. So as I said earlier, gonorrhea and chlamydia, T. vaginalis, trichomona, they do coexist together. So please, you must think about this. And as I was telling you about those two studies which are done in Harare recently, they were doing research mostly on asymptomatic patients. They were offering free investigations and treatment asymptomatic patients, and a lot of patients benefited, and they found. I'll try to get hold of those studies. I'm also very interested at what was the volume which was examined and what did we got out of the study. This one I mentioned earlier, if you see urea plasma, you don't worry about, but if it's a genitalium, you must think about treating them. So after you've done your investigations, contact tracing is very, very important. If you don't do a contact tracing, job is not done. Simple examination, investigation, and treatment is not enough. This is a very, very important part of the treating STI, contact tracing. And the higher priority are the patient's current sexual partner, or if they are sharing needles or sharing drugs, we have to trace them. So we must find out about the previously sexual injecting partners also, besides the current sexual partners. So as we are all aware, these infections can pose vertical transmission to unborn babies and household contacts also. So please, we have to do contact tracing. We must emphasize, we must ask the patient about his current partners and his previous partners. Some guidelines suggest going up to previous 6 months. After the tracing, the partner notification is also a very important aspect of managing STI. So as a group, when you manage STI, after contact tracing, you have to notify the partner or partners. So individuals who are testing positive or who test positive, they should be notified. So these are the group of illnesses. We should tell them that their partner is positive and they should come to the nearest available facility to get treated for these kind of infections. So which partners should be notified? This is a very difficult question. You need to be guided by the patient's sexual history and your local guidelines. But as I mentioned earlier, 3 to 6 months passed, or if there are no partners, then the recent sexual partner has to be notified. So who notifies? This is a very important question. A very, very important question. We face it every day. I'm sure Jackie faces every day. And I'm sure my friends, colleagues sitting in rural setting and urban setting, in especially districts, small clinics, they face it every day. They found a patient, either clinically he's showing signs and symptoms of a sexually transmitted infection, or his investigations have come positive, who was asymptomatic. So who notifies? Doctor who makes the diagnosis, or the patient themselves? So this I leave it open to the forum. The guideline says the doctor who makes the diagnosis has to notify. In our settings, we have environmental health technicians. They help us to trace contacts like they do contact tracing in TB. We should use the same team in the rural settings. In urban settings, definitely now we have means of communications, and I'm sure it would be not that difficult to notify the partner. There are consequences I do face sometimes when the patient requests you, please do not tell my partner. These are very medical legal situations. Here you have got a patient who has tested positive, or is definitely have made a diagnosis clinical of syphilis or maybe HIV, and there is begging you not to tell my partner. This is a topic I think for another presentation. I will request. Actually, I'll beg Jackie to give me an opportunity, and we should have a whole presentation on this. This is a very important aspect. I'm sure Jackie is listening very carefully, and we should have a presentation. We face it every day, and how to get out of the situation. Actually, the patient has to benefit, and the person and the partner, in mostly cases, the female partner sitting at home and doesn't even know what happened, what hit her. So we need to see. In certain instances, we have to do enhanced contact tracing, especially when there are outbreaks, relationships with a power imbalance, there is domestic violence, serious infections, child safety is involved, pregnancy is involved, and definitely we see literacy and language barriers, cultural issues. We will definitely have another presentation on this topic of notification. So just to summarize, the treatment of STIs, 3 bacteria are generally curable with existing single dose remedies. Most effective medications are available for HIV and herpes now, and Hep B antivirus are helping a lot of patients. And I've seen a lot of patients with Hep B being treated with antivirals, becoming seronegative of Hep B. So treatment is available. We are the flag bearers of this. Now, before I go into the treatment, which are the regimens which are being followed, I will again request my colleagues to follow the local guidelines. This is very important. You must not treat according to your knowledge, but whatever your local guidelines tells you to. The UK guideline or the Australian guideline or the South American guidelines or the North American guidelines might show a little bit differences, but follow the local guideline. This is very, very important because of the research done in that particular area, especially like in our African context or in Southern Africa. So these researches, they come up with this solution for the benefit of us and benefit of our patients. So we should definitely follow the current guidelines. So for us, while in Zimbabwe, we follow ADLIS, which is really a very good collection of treatment for people sitting in their rooms in the rural and urban settings, and it guides you what can be done, and they give you first line treatment and the second line treatment. So in this, if you see a patient with a urethral discharge, according to ATLAS, the first line treatment is kanamycin, aminoglycoside, and then if you don't have the aminoglycoside, you can use ceftriaxone in combination of doxycycline. So we are treating both chlamydia and gonococcal infection. Or you can use azithromycin as a single dose. Second line treatment as per ADLIS, so it's ceftriaxone or cefixime per oral, 400 milligram single dose, and metronidazole definitely if you've got trichomonas. We should not be scared of referring a patient if you think that the patient is resistant or is not responding to your second line of treatment. The patient should be definitely referred to a specialist or to the genitourinary clinics. In Harare, we have got Beatrice Infection Disease Hospital and St. Forgotten the name of the hospital. Anyway, I'll remember it and I'll come back to it. Now, if you see a female patient as per ADLIS, this is the treatment. I won't go into details because the ADLIS is also available online. I'll give you the link of ADLIS. You can go online and you can easily see what is the first line treatment, what is the second line treatment, and the patient benefits, you benefit. Be in private or be in public, you can treat easily. Now we come to the genital ulcer part. So interestingly, I was reading the guidelines in UK and Australia. They are also following the same what we are following in Zimbabwe or SADC. They are using benzathine penicillin, one stat dose, and ciprofloxacin for 3 days, recyclovir. So if you can see, they have actually did a syndromic treatment which herpes virus and syphilis together. So benzathine penicillin single dose 1.44, 2.4 megaunits. And acyclovir also is 200 milligram 5 times a day. It is recommended. And if the patient is penicillin allergy, then you can go on to the doxycycline, which has to be used for 20 days. This is the treatment for syphilis, if you can see, as I mentioned just now. In syphilis, if it is primarily syphilis, then you can treat with benzathine, single dose, or doxycycline in case of penicillin allergy, or erythromycin, 500 milligram QID 4 times a day, like 14 days. And if you are suspecting late syphilis or during pregnancy, you use benzathine penicillin. Please make sure it's not benzyne, it is benzathine. It's very important. This is what is written in the this slide also. If you look at the last line, benzathine penicillin, not benzyl penicillin. And here, this is a very important paragraph that if you have a history of treated syphilis and the RPR titer is low, non-reactive 1 or 2, which is actually consistent with previously treated syphilis. So specific syphilis markers such as EIA, TPPA, and FTA, they remain reactive even after treatment, then they can actually remain reactive for life. Whereas the RPR titer steadily falls to 0. And if there had been no testing with the previous 2 years, then the patient should be treated as having late latent syphilis. And there, in the late latent syphilis, you'll use benzapenicillin 1.8 grams, weekly intervals, 3 doses. And if there was a previous test within 2 years and the patient has seroconverted, RPR has risen to 4 folds, then they should be treated having early latent infection, benzathine penicillin as a single dose. Mild to moderate PID. First line, amoxil, doxy, and metronidazole. Second line, norfloxacin, doxy, and metronidazole. Alternative to penicillin allergy, you can use erythromycin. If it's severe, then we go to benzyl penicillin. Here you will use benzyl penicillin, not benzathine. And condylomata acuminata, I've showed you some slides. The recommended treatment as per address is podophyllin paint. It should be washed after 4 hours of application and should be used once up. If the patient is pregnant, we do not use podophyllin, or if it's urethra or anal mucosa involved, you do not use podophyllin. You refer them for cryo or electrotherapy or surgical excision. Pubic lice and scabies, you can use benzyl benzoate as the first line treatment, or second line, if they don't respond, you'll use gabapentin. Local application. Ophthalmia neonatorium, you can use kanamycin or ceftriaxone and erythromycin. And at birth, they usually instill tetracycline as a prophylactic in our settings. So what is our South African colleagues doing? You will appreciate that they are doing the same. What they are doing is they are also treating the gonorrheal and the chlamydia infection with ceftriaxone and azithro. They didn't mention anything about the aminoglycosides here. And if it's T. vaginalis, then they add metronidazole. If there's bacterial vaginosis, metronidazole. If it's yeast infection, clotrimazole. If they are suspecting syphilis, then like we mentioned, they're also using doxy and benzathine penicillin. And herpes, definitely cyclovir. And if it's Haemophilus ducreyi, they use azithromycin. So more or less same in South Africa. SADC countries have got the same regimen. So I'll show you two slides from Australia and UK, and you'll see more or less it's the same azithromycin and ceftriaxone and metronidazole. And in ulcer disease, first episode, they are giving the cyclovir with benzathine penicillin. So they are covering syphilis and herpes as a syndromic treatment. Same treatment in our Australian and UK as I mentioned, but if you see here, if the only thing important is Mycoplasma genitalium, they have used moxifloxacin. So what are the barriers for patients who do not seek treatment? So recently a study was done by Leif Klister and colleagues, and they found the patient's perspective. End of the study, they said the patient don't seek treatment because they are not happy with the heavy rush in the outpatients or the medical clinics, long queues, staff's behavior, and the limited information they are given by the healthcare workers, and the lack of confidentiality. So these are more important factors when the patients decline seeking STIs. There are other factors also, but these were highlighted. And from the healthcare providers' perspective, they said that they would get better if they are given extra time and training in STIs, more educational material, visual aids, and definitely they were worried about the consistent supply of STIs. As we are doing syndromic treatment, when one part of the treatment is available and another is not available, this is really very bad for the patient. He doesn't like it, and they are lost for follow-up, and then they develop resistance because other part of the treatment was not available. I didn't complete his treatment. Now, how to control the spread? So two very important factors: the behavioral change, which is a very complex thing, and health services for screening and treatment of STIs. WHO is doing a great job. Our own Ministry of Health is doing a good job. We are doing a lot. I'm very sure my colleagues will appreciate that, and they are also doing in their practices. They provide as much information they can to the patients and recognize the symptom, seeking early treatment, encouraging sexual partners to come forward, and public awareness. As I did mention earlier in that study, lack of training among health workers is one problem which they really worry about in providing treatment to the people. A small slide just to summarize how the diseases are. Remember, I showed you a very old slide. This is a newer slide which summarizes the prevention and the transmission, how the STIs can be protected, and one can stay away from STIs if he follows these things. This is my favorite slide. It shows you in one slide how to practice all these things, what things to be used, about your partner, talking to your partner, and if you unfortunately test positive, you go to the nearest center. So the take-home message: you have to be very confident when you treat a patient with sexual history and sexual complaints. You should be confident treating them. You should follow local guidelines. This is of primary importance. You should follow local guidelines and try to be up to date with the local guidelines as much as possible. You phone your colleagues, you phone whoever you can in Ministry of Health, and must time to time ask if there is any improvement, any changes. Compliance is very important. We must mention it to the patient, to our clients, that compliance is of really prime importance. And then contact tracing and partner tracing is very important in the treatments. And we should offer some sort of counseling. We should, so that the patient goes very satisfied that he has been seen nicely. You need more information, you can go onto the WHO site, you can go to the CDC site, and as I mentioned earlier, Melbourne Association of Sexual Health Australia. This is the Australian side where you can get the Atlas of Sexually Transmitted Disease with the images, and it's free of charge, which is very important because many other sites, if you try to go like BMJs and Lancets, they don't allow you without coming into their site without paying a subscription, and which is really phenomenal. Thank you very much. You have been a very patient audience, and I really thank Jackie and Invectus for giving me an opportunity to present this refresher for STI. Thank you very much.
Thank you, Dr. Syed. I think it's an area that we don't talk about very much and we don't educate on very much. And I think it's an absolutely critical area for doctors to be competent with. So I'd like to thank you for a brilliant presentation. I think we're going to need to post your slides tomorrow on the group so that people can be more informed. And it was, I think, quite a graphic, but a very, very, very important presentation. So thank you so, so much for your effort in putting it together.
I'm obliged. Thank you.
Thank you, Pride. Can we stop the recording? Okay, thank you, everyone. Can you hear me? Pride, can you hear me?
Yes, we can hear you.
Yes, we can hear you.
Sorry, I pre-recorded that just because of some technical problems. There have been two questions in the chat. One is whether there is one treatment, monotherapy for STIs. And I think the answer to that is no. I'm not sure if Dr. Syed is on the call yet. Are you on? He hasn't managed to connect. Like I said, we've been having some technical problems. But no, there isn't a single treatment for an STI. I think it's important to make the diagnosis. And I think it's also very important to be treating it. The second question was, I'm just flicking back through the chat. Is HPV one of the STIs? Yes, it is. And it should be tested for. Particularly, you can use VIAC. There are new point of care tests that you can use, and they can be used for picking up HPV, which is obviously going to become as a problem with cervical cancer in the long run. And then one of the other questions, I'm just flicking through the chat here, was what NAAT do in identifying STI. It's a nucleic acid amplification process, and it can be done as a point of care test. It's much cheaper, and it is a much more diagnosis, and as a result, you don't have a patient who's lost to follow-up. So I think those were the main questions. Does anybody else have any questions or comments on all of this? There have been a lot of thank you very much comments. I can't see Dr. Nasir on the chat at the moment. Like I said, we've had some problems with technical connections in Zoom at the moment. So are there any other questions? We will post the slides on the chat tomorrow. Does anybody else have any other questions? Oh, here's another question. To a familiar treatment regimen, or does treatment differ from country to country in SADC? So I think there are slight differences, but they are generally the same. And I think that referring to any of the websites that Dr. Nasser put up is a good idea. CDC, WHO, and the Melbourne site will give you a very good idea of how best to treat it. Another question, in your experience, what percentage actually get contact tracing or notification? And I would say that that is quite low. A lot of people are very hesitant to tell their partners. And I think that contact tracing is hugely under-resourced here. And I think that it's a big part of the problem in an under-resourced setting. Ceftriaxone, has it changed from 250 milligrams to 1 gram? I would usually give a gram of ceftriaxone if I was going to give ceftriaxone. I would rather over-treat it than under-treat it. And I think another question, can you use a weekly dose of ceftriaxone a gram a week for 3 weeks for the management of syphilis for patients not sensitive to penicillin? I'm actually not familiar with that answer. I would say that a gram of ceftriaxone would be more than adequate for a 3-week treat for syphilis. The rest are thank yous. Excellent presentation, many thanks. Thank you, Dr. Nasser. Dr. Rapiti has mentioned that chlorine dioxide can be effective to treat HPV. That's definitely something that can be considered. And I think the most important thing, there was so much information in those slides, that I think the most important thing is that I will share them now with Pride, who can put them on the group, and then people can review them at their leisure, because there was a huge amount of information in those presentations. So thank you, everyone. Pride, can we end the recording?
Thank you.